So, welcome everybody. This is a symposium on a very emerging, very important and a very hot topic, extremely essential for the future of the generations to come. It's on myopia and I hope, Dr. Satya is here, Dr. Shilpi is, yeah, yeah, she's here. Vivek, Dr. Vivek, please, and whoever is in the expert panel can come up so that we can go on. So I'll just start the introduction about myopia and set off the talks to come about myopia and how we're going to manage and tackle this. And thank you everybody for coming here to discuss and talk about this very important subject. So everything was pretty peaceful on us, and actually in one of the previous a long time ago, of course, symposiums, I was in a cataract refractive surgery where I presented about myopia. Unfortunately, I used to present myopia in front of cataract refractive surgeons who were, to say the least, had financial considerations in the whole process. One gentleman got up and asked me that we understand myopia is increasing, but then what's your problem with that? He was rather concerned about what I'm trying to do is reduce the tap of possible prospective refractive surgeries he may have in the end. But anyway, I'll talk about this very important paper that kind of made us sit up. There are a lot of doubts and a lot of issues with this paper, but still this paper highlighted the most important thing, that yes, across all races, across all countries, generation after generation, there is a progressive increase in the prevalence of myopia. We know that refractive error still remains and has been for a very long time the most important cause of visual impairment and possibly the second largest cause of treatable blindness. But till some time back, it was not really a concern for us. One of the papers which we had done and which tried to find out the prevalence in northern India, it came to about 13%. 3 to 4% cumulative incidence didn't sound so big when East Asia you have 50 to 80% prevalence and incidences ranging from 10 to 14%. So it didn't look so bad. But when we compared that data which we found from a very similar study done in the same place a little over a decade ago, we found that the prevalence had actually doubled almost in that area. So that was a cause for concern. Indians as a race are really not immune to this. And this was a very interesting study from Singapore, where first generation immigrants had about approximately 12 to 14% prevalence, something that we see in urban Indians, or we saw some time back. And the very second generation, or the children of these parents, actually had 28%. So they were quickly imbibing the risk factors that were prevalent in in Singapore and in the people there. So this was again another meta-analysis subsequently. One of the, like I was highlighting, the problems with the Brian Holden paper was that they ignored Indian data and they said there was no robust study from India. So actually, 1.4 billion population was ignored in that, landmark path-breaking paper that we all love to quote. So this was a meta-analysis that we did. And everything else aside, this was over 4 decades, all published literature, no doubts, there was nothing. It was obvious that myopia prevalence was increasing, but something which I personally was very surprised, because before that I used to think that rural areas are not really concerned, we are not concerned about myopia, but there was a significant increase in the last decade in rural children. And remember, all these stats, all these papers are pre-COVID, and we don't know how things have moved significantly past COVID. Myopia is, again, we think it's a very benign disorder. We just need to give glasses. But remember, high myopia is associated with some very major, irreversibly blinding conditions like pathological myopia, retinal detachments, retinopathies, cataract, glaucoma. So all these are very, very important and something we need to be able to prevent high myopia by acting today. Again, treatment options are cheap. You just need to give a pair of glasses. But again, in the US, and this is almost 5 or 6 year old data, the cost of providing spectacles was just 4.6 billion alone in the US. And you can imagine the cost in India, and this is only spectacles, not refractive surgery, what Partha charges. So preventing myopia has now become the most important thing of preventing progression of myopia. We know there are a lot of risk factors associated, and outdoor activity appears to be the most important preventive factor. And about 2 hours a day, most studies have tended to agree, are the important things. The other risk factors that are possibly modifiable, unmodified, would be the pre-myopia understanding that they are lower hyperopes than age-matched normals. With age, you find them to be progressively increase in the prevalence, but younger and younger onset of myopia we are observing. Parental history of myopia, parents are myope, both parents are myope, almost 3 times the risk of having progressive myopia. Girls, for some not so very clear reason, possibly less outdoor activity, are more at risk. But the environmental factors have the ones that have changed, because the genetics has not changed over the last 3 or 4 decades, but there has been a massive explosion, and probably the visual environment, basically a lot of near work, smaller distances, longer hours, association with binocular vision problems and accommodative lag are the key factors that are driving this myopia epidemic. And our decisions to intervene should be based on identification of clear risk factors, and the most important thing is documentation of myopia progression. Myopia is treated with spectacles. Myopic progression requires alternative modalities that we'll be discussing today. I'll just quickly run through just a couple of more things just to highlight the importance. Treatment strategies should be based on risk benefit to an individual, associated conditions, patient's lifestyle, economic, and compliance. Remember, it's not easy to put a drop of atropine in a child's eye for 2 years every night, continuously, at least for 2 years. So I've never possibly completed my dose of antibiotics for, say, URI or something, which may be just 5 days. So remember, these are big challenges we need to face. The other alternatives, opticals, will be discussed today, are really path-breaking, which are changing, but again, in controversies, we'll discuss what are the limitations of these. So everything sounds so good, and that it's perfectly made now for preventing myopia progression, but remember, there are a lot of catches to it. There are a lot of new drugs on the block, which are being tested, and let's see how they turn out to be, and how they impact myopia progression. But again, to highlight, the most important thing is lifestyle modification. With every child, with every parent, with every caregiver, we must insist this. There are a lot of solutions for myopia management we'll be discussing today. Each one has its place, and it's very, very important for us to understand them. It's a cause for concern, not alarm. We know outdoor activity works. We'll discuss various treatments, but it's important to understand that everything has its place and shortcomings. Everything that we'll discuss today have actually been published recently in an IGO article among the consensus guidelines, and some of it we'll be going through today. Thank you. So now we'll move on to the next set of speakers for covering the various aspects of myopia management.
Thank you, Rohit sir, for setting context to the epidemic that we are all facing. And fortunately, there are still a lot of options that are coming up, though no solution yet, but still there are a lot new things that we keep hearing of every day. I invite Dr. Shreya Shah to talk about the optical interventions.
Good afternoon all, and thank you Dr. Rohit Saxena sir for inviting me for this speaking on optical correction, optical intervention. So optical intervention for retardation of myopia progression. And if you look at what is myopia, everybody sitting here knows what is myopia. When there is eye as accommodation at rest, when eye focus, it focused on retina, but if it doesn't, because of elongation of ball, that can be a blurred vision, and what we call is myopia. So if you look at mechanism of myopia, usually higher lag with near work amongst the myope leads to hyperopic defocus, leads to cue for the axial length elongation in turn. So whenever there is myopia, you can see that whenever we do the single lens correction, this puts the image back on the macula, but the rest periphery will be a hyperopic defocus. So whenever there is hyperopic defocus, that is the cause for the axial length elongation. So what is an ideal which can cover the complete focus on the posterior part of the retina. So whenever we talk about, Dr. Rohit sir has said everything, and whenever we are talking about retardation of myopia progression, lifestyle modification is the first important part, pharmacology and optical intervention. So when we look at the optical intervention, we have many options available, especially for accommodative lag. We have bifocals and simple progressive addition lenses. And to treat the hyperopic defocus, there is a defocus theory. We have Hoya Myosmart, SLR Stilet, Zeiss Myocare and Nova horizontal PAL, and contact lenses, of course, lot many available like MySight, Ability AccuView, multifocal and Ortho-K. So let's talk about bifocal and PAL. We have this study, the bifocal actually has got reduction in 1 and minus 1.25, you can see here, but no replicated in other studies. So still it has got effect. If you look at the PAL COMET study says that it is best with kids with esophoria and large accommodative legs. So it corrects 0.64 diopter treatment effects over the 3 years, and lot many studies again have done but not clinically relevant. So lot many studies for bifocal and PAL has been done. What are the pros of executive bifocals? It is really inexpensive. Familial concept to parents may help with reading like binocular vision function and accommodative lag, combined well with high doses of atropine, but it may not be referred for spotty kids, and effect wise it is little below advanced DIMS and Hall technology. So let's look at defocus theory, which is first one is DIMS technology, which is defocus incorporated multiple segments. Here there is 9.4 millimeter clear zone is there, and surrounding that 33 millimeter peripheral zone, which is responsible for creating the myopic defocus. In this honeycomb, if we look, each 1 millimeter has got lots of lenselet of plus 3.5 diopter. So if we look at one pupil size area, there are two areas, defocus and focus, and both are 50-50% in. So this has got a densely within this honeycomb. So if you look at the animation of this is a clear zone and this is a treatment zone which comes for the DIMS technology. And how does it work? When we put the lens, it clears the defocus on the peripheral retina. There are lot many lenses available which is ranging from -10 and cylindrical -4. So again, there lots of studies have been done for this DIMS technology, 60% efficacy and 70% children progress less than 0.25 diopters. So what are the pros of DIMS? Longest myopia control spectacle study, that is 6 years. Average cumulative myopia progression is less than 1 diopter. Average axial length elongation progression is 0.6 millimeter in 6 years in DIMS study, and no rebound effect as compared to the initial 2 and second and third year of study. It is definitely very costly. Depends upon measurement of monocular pupillary diameter. May have to select the frames sometime from the adult section. May have to compromise for little bit part of treatment on it, and quality of the vision may not be acceptable for older teens and kids which usually place the spots. So let's look into Hall technology. Again, there is a central 9 millimeter of clear zone, 11 rings of 1021 contiguous touching to each other aspheric lancelet, which is of 1.12 millimeter in diameter, and it has got same geometric lancelet in the same ring, but each ring has the different geometry. So space between these two is used for the clear vision, distant vision, and this in turn together causes the volume of defocus. So this is simple, a small innovation. It is 1021 lancelets, concentrating ring, 11 rings, and it gives the clear vision. So this volume of defocus actually has peripheral focus and simultaneous focus. So if we put the normal single lens, that is a criteria for, that is a activity for axial length elongation, but here it is two contrasting signals falls on the retina to correct the emmetropia, and again falls in front of the retina to create the myopic defocus. So again, this is available in lot many numbers. Lots of studies for Hall technology is done, that is, but mainly these studies are for 2 years. This is the result for myopia correction, axial length growth correction, even that is a part-time versus full-time study, rebound effect, effect on reading speed, effect on visual acuity and function, effect of halt on retinal shape and choroidal thickness. So lots of studies are available. I do not have any financial interest for this. When we look at the pros of halt, excellent efficacy, premium product, even profit center for the practice, and flexibility in frame selection. Again, no reading ad is there, it's costly. Quality again is not too much acceptable for the kids who play sport. So third technology came is CARE technology. It's a cylindrical annular refractory elements inspired by ortho-K principle, ring-like imprints on the cornea following ortho-K, alternating defocus and correction zones expanding towards the periphery, which this is a Zeiss Myopia CARE technology. It has got two pillars. Pillar 1, there is anterior pillar which has got CARE technology to deliver the stop signal, and there is a pillar, posterior pillar, which is for clear focus design for correction of the refractive error. So this in turn, this is the detail that has got clear zone, functional zone, height and width of the CARE, distance between microstructure and size of the clear zone. This is intended myopic defocus, and usually it is good for maintaining clear vision in all gaze. And again, each lens has fill factor like functional zone versus clear zone. This Zeiss Myopia has 0.5 fill factor, and that is optimum myopic defocus is plus 0.5 to plus 5. So this in turn, when the light focuses through passes through the elements of the lens in refractor, this causes the forms of caustic, and then in turn creates the blended distribution of myopic defocus. Then it acts as a EDOF lens. So we can just compare it is a extended depth of focus, and it comes in two parts, softer version and the harder version. So Myopia Zeiss also, there are lots of study, but they show a 30% efficacy, no clinically significant. The fourth one is horizontal PAL, which is from Nova, that is a horizontal progressive addition lenses. There is not much of a study available for that. So spectacles are an integral part of any myopia control strategies nowadays, and let's look at the contact lenses. So we have option is multifocal contact lens, that is a simultaneous correction for foveal vision and myopic defocus. So again, there is a concentric ring as distinct zones of the alternating distance and relative addition power. So we can see there is a treatment zone and the correction zone. Usually approved by, this is MySight Cooper Vision lens, which is only approved lens by FDA. I don't have any financial interest. Central distance correction and with peripheral addition is available. So this is the way how MySight from Cooper Vision works and creates the myopic defocus. So MySight efficacy has been again studied for 109 children, and it has shown 59% reduction in refraction and 52% reduction in axial length growth. So this is another newer lens is pre-clear lens, which is not available in India. So it is a daily wear lens, monthly replacement is possible, and clear distance D lens with 1.5 millimeter concentric optic zone. Variable ads are available, and both have toric options also. Another lens available is VTI natural view lens, that is again EDOF lens. So again it is a daily disposable lens, and other options, lots of options. Swiss lens, only I have 2-3 slides. Swiss lens, Essentia Milo lens, which all are not available in India. So when can we start this contact lens? As soon as child can handle 2 contact lens wear. Talk to the parent about myopia management, as Dr. Rohit sir rightly said, when you suspect pre-myopia. And myopia can continue to progress up to 50% stability, usually at age of 15, 75% stability at the 18. So you can switch to the single vision lens. And again, the ortho-K last technology available, which is a reverse geometry technique, works on reducing peripheral hyperopic defocus. So again, that we all know how does it work, increasing peripheral myopia defocus. And again, the 2 years RCT has been done. Meta-analysis says that 0.18 millimeter reduction as compared to the normal control over a period of 2 years. Rebound still not known. Accelerated progression after this. And corneal infiltrates and the infectious keratitis is the primary concern when we are giving ortho care. Because microbial keratitis in children 13.9 as compared per 10,000 patient as compared to adults, that is 7.7 as per 10,000. So again studies, you have to, this study says that you have to weigh benefits versus risk whenever you are prescribing. So deciding between ortho care and multifocal lens is simple. If this 9-year child, refraction is this and keratometry is this, we can give multifocal, no RK, orthokerato because of flat cornea. So you have to take care. So this is simple comparison. We have created all options available, and there is one Cochrane study, 6772 children have been created. What is the moderate certainty evidence and what is the certainly evidence progress. So in conclusion, patient and child education, outdoor activities, combination of pharmacological with optical seems to give more benefit. And how do we just judge the success? Positive, meaningful impact refraction on axial length and refraction, no rebound on scissors, and minimum negative impact on visual function and evidence of beneficial effect on anatomical. We all do in one capsule, still some children will cry, some children will laugh. Thanks to my teachers, thank you all for patient listening and giving me 1 or 2 more minutes. Thank you.
Thank you for compiling all the options that are out there. But as was said, we really don't know the long term, still keep going back and forth between lenses. So I'd like our expert panel to give their experience on what they feel works well or how they would manage.
Yeah, I think if you ask me, there are different reasons for this myopia progression, right? So she talked about first, simple PAL lenses, right? Or even simple giving bifocals or multifocal, the lower segments. Then we talked about, the different type of, the lenses where we can change the, the peripheral hyperopic defocus. And then we talked about induce the myopic defocus. And then, the options of various, the contact lenses. Having the same reason, we are trying to reduce the hyperopic defocus. So all the patients, they do not fit into one category. So you need to find out, this particular patient, which is the primary cause for his, the axial elongation. So depending upon that, many times I have come across when I started using pharmacological therapy, they showed very good response for, the year and a half. And then I realized, okay, this particular patient also has, the hyperopic defocus. So these are the candidates. No one therapy is, the rule of thumb. You have to, keep finding out what is the primary or predominant cause, and then accordingly you have to take. We do have a lot of options. We have to choose smartly what is the best, and then take forward. If we talk about even pharmacological therapy, nowadays we know that, the paper coming from US saying that it doesn't work in children's in US, and we are using it since last 2.5 years. So we have seen that one-time dose, probably it's a dose dependent. So I do start in my practice sometime 2 times in a day, like morning and evening dose, and we need to look at like whether does it works over a period of time. But as we discuss and we always debate on this, that there is no one-point solution. We have to keep taking a decision smartly.
I have a question for Rohit sir. I would like to know about your preferred practice. When you give the specialized classes for treating myopia progression, do you combine with low dose atropine, or only you are preferring glasses?
So I would always start one therapy at a time, unless it's a very rapid progressor, and even then I would want to know the effect of one treatment. So I always correlate it with like glaucoma therapy. I mean, unless the pressures are very, very high, you would start one drug at a time, know the impact, whether it's effective or not, and then decide whether you want to supplement or replace. So whether I start atropine or I start refractive optical treatment, I will always keep one intervention, follow up for maybe say 6 months, see the impact on the refractive error change and the axial length change, and then take a call on whether I feel a supplementation. If it's moderately responsive, that means some work is happening, yet I feel he's increasing rapidly, I would probably supplement. But if there is no significant impact on 6 months, maybe I would think of a switch. If it's on atropine 0.1%, maybe I would think of shifting to 0.05%. So that's how I would, grade treatment. Most important thing, know progression, know the rate of progression, so that you know the impact of what treatment you are giving, and subsequently you are in a better position to decide how to do your change in individual child, rather than just randomly taking a call that this doesn't seem to work, let me add that, that doesn't seem to work, let me put both of them together. So hard data on every child is probably how we can give tailored interventions.
Thank you, sir.
I have is like, yeah, go ahead, sir.
Acceptance. Sorry, what are better? The single vision
Acceptance,
spectacles.
yeah.
There is no doubt. There is a little bit of, some children do find it a little, very perceptive children. So you're playing with light, you're cutting, it's like multifocals, you get better and better, but the best vision is by, a clear lens, a single vision lens will always give you better vision. The moment the child looks through the side with these spectacles, you are cutting off 50% of the light from going onto the fovea. So the quality of the image is going to be less. So children, perceptive children will have a problem. Sometimes children have a problem if the lens, if the because it's from the mid-periphery onward. So the spectacle size has to be a little large. Otherwise, what happens is the child starts looking near from the periphery part of the lens for too long, and then again he has blur or vision-related problems, or a decrease in contrast, which has been definitely documented in these spectacles in the periphery. So these are issues that the child has, but as of now, I haven't had any child who has stopped using these spectacles. Maybe the parents are so pushy that, these are very expensive lenses, so you better use them, or else. So maybe, but I haven't had any child who has stopped because of, optical reasons per se.
Actually, I have an experience of about 60 patients. I have given my DIMS glasses, and they've come for a 1-year follow-up. They are doing quite well, so there is no problem actually. Yeah, with these DIMS glasses. And again, we can always try a combination therapy.
Sir, I have one doubt. Whenever we start these spectacles for these myopic children, what is the dead end? How do you decide? Like suddenly if a patient says after 1.5 years, I want to shift back to normal specs. Like for atropine, there is 2 years or 15 years, whichever is the long. Do we know that when do we stop these glasses? When is there any point when we can really shift them? Stability of these many years, or any such rule with respect to spectacles?
Yeah, so I think there are two things, you need to keep shaking the axial length on a periodic basis.
And the refraction.
We came out in a guideline that every 6 months. At the same time, you need to do a peripheral, the hyperopic refraction that you need to, if you have the open field autorefractometer, then same parameter you need to follow, and then see, now after a period of, 1 year or 2 years, there is no much change in the axial length and peripheral hyperopia had been reduced, then probably that's the time. But then again, we advise even for pharmacological therapy, the slow tapering. So same thing is more or less applicable for these DIMS lenses.
How do we taper?
You want to add something, Dr. Rohit?
So really tapering is something that has not been discussed with spectacles.
Correct.
But there is a time limit. They say that the child should be wearing these glasses for say 12 hours at least during the course of the day. So subsequently you could, if child is uncomfortable, you could think if everything is stable. Even for atropine, I would say there is no end point. I mean, I have a child who's been on 5 years now, and I'm kind of trying to taper them off. Some of them who progressed after tapering and stopping, I have switched to spectacles. So there is no end point. So there's no end point to myopia therapy. We can never guarantee that they'll not progress. We've had young adults in their 20s come with progression of myopia. So it's a little challenge right now. But for all interventions, as we'll, I think, go on and discuss, it's probably individualized, tailored approach. If he's progressing, you may have to go back, you may have to, like tapering for atropine, we know, so for this from 12 hours, you can bring down to 6 hours and then go. But there is, this is just, I'm giving you, just a clinical experience. There is no at all study or information in the domain that we can talk about.
I have a
There is
very,
one study.
I have a very basic question. When do we start? Do we have to document an axial length progression and then start pharmacological therapy, or can we start it empirically, and or the spectacle therapy, the special?
So any myopia therapy, you need to identify the disease. The disease that you're treating with this, any treatment we're discussing is progressive myopia. So we need to document progression, we need to document rate of progression. For two reasons. One, because then only we confirm the diagnosis of progressive myopia, and two, whatever intervention we give. So only then will we know how much impact we have made. A child who was progressing with 1 diopter a year, we bring him down to 0.5 diopters a year, great impact, I can supplement. A child who was increasing with 0.5 diopters a year, I bring him down to say 0.3 diopters a year, the impact is the treatment is not working. I should switch the treatment and look for, optical versus pharmacological, whatever was working.
Yeah, so we'll take the discussion in the end. I invite Dr. Rishikesh to talk to us about pharmacological interventions. So, all said and done, the optical intervention is expensive. So that's where, in cost side, the atropine holds good.
Thank you. At the outset, I would like to thank the scientific committee, AIOS, and NTOD for this wonderful, it is indeed a privilege to be a part of this August gathering of people interested in myopia. Actually, it's like myopiology, or a science which deals with going into the depth about how myopia progresses and what all treatment options we have. We have just covered optical interventions, and my topic will be on pharmacological interventions in myopia. Actually, last year I attended the WSPOS at Milan, and as Rohit sir had suggested, there is a school of thought that you don't need to treat myopia. Let it progress. After some time, it will stabilize, and then you can treat it with some refractive correction as well. But there are associated risk of ophthalmic complications, and many of these are visually blinding. Dependency on glasses makes the child visually handicapped without glasses as such, especially the higher power glasses. Financial burden because of change of glasses or contact lenses, and potential surgical interventions in terms of complications related. And a psychological impact, that is a high index glass does induce some amount of low self-esteem in the child. So when we are considering treatment for myopia control strategy, we need to understand that there should be a strong clinical data to support the effectiveness and established treatment protocol. It should be cost effective, because I think optical or DIMS glasses are not cost effective as such. It should be easily available. It should be easily used. There should be ease of use, minimal or no side effects, because we are going to treat these children for prolonged period of time. There should not be a rebound phenomenon. Once we stop the treatment, there should not be reversal of myopia. Also, there should not be something like a tachyphylaxis, like prolonged period of time, the effect of the drug reduces. There are different treatment modalities for control of myopia suggested, but with time we have realized that low dose atropine and DIMS, they definitely work, whereas lifestyle modifications and orthokeratology, they might work, but they may not work alone. They might be supplementary treatment to optical or pharmacological treatment which we have. So coming to low dose atropine, actually it is the most commonly used method for myopia control all over the world, because there is a data from large multicenter randomized clinical trials, especially ATOM-1, ATOM-2 and LAMP study. It is in India, it is available as 0.01% atropine sulfate. And to tell you in short, atropine, diluted atropine has actually revolutionized the treatment of myopia control. The advantages of using low dose atropine is that there is a strong clinical data. I will be sharing a few points from that. It is availability and cost is not a problem, and ease of use. You have to simply apply one drop, but as Rohit sir suggested, for prolonged period of time like 2 years, it may not be a great idea, or it's not that easy. The problem disadvantages with atropine is for higher concentration of atropine like photophobia, a rebound phenomenon. Also, all the clinical data is till 14 or 15 years of age. We don't know how atropine works beyond that, but it can be used, and there are no side effects using after that. The mechanism of action are proposed to be one of the three or a combination of three. One is that atropine causes release of dopamine in extracellular matrix and vitreous, thereby inhibiting retinal signaling process, and which in turn leads to inhibition of axial elongation. Also, it is believed that atropine causes release of extracellular matrix by the scleral fibroblast and directly inhibits the axial elongation. The third theory is that atropine reduces the extracellular matrix at the choroidal level, thereby increasing choroidal perfusion and choroidal thickness, which in turn leads to inhibition of axial elongation. Whatever the mechanism be, one thing is for sure that the routine or the well-known muscarinic effect of atropine perhaps, or the effect of atropine on accommodation does not have a role in myopia control. There are three studies which have been done so far for the use of atropine. The first one among them was ATOM-1. ATOM-1 was started somewhere in 2007-8 to find out the role of 1% atropine sulfate, which was commercially available in control of myopia versus placebo, and they basically studied it for 3 years, out of which 2 years was the treatment part and 1 year was the washout period when the drug was not given. And at the end of 3 years, they found that yes, definitely atropine does arrest the myopia progression, but obviously 1% atropine cannot be used commercially. So they studied the other concentrations of the lower dose concentrations of atropine in ATOM study. And they found, again they divided into 2 years of treatment phase and 1 year of washout phase. At the end of 2 year treatment phase, they found that 0.5% atropine actually performed better than the other two, including 0.01%, which we use. However, after 1 year of washout phase, they found that the axial elongation was more with 0.5% atropine compared to 0.01% atropine. Also, progression of myopia was more in 0.5%. So at the end of 3 years, overall, the progression was minimal with 0.01% atropine compared to the higher concentrations which were used. The LAMP study was to investigate the efficacy of low dose atropine, the 0.05%, 0.025%, and 0.01%. The study is still being done. What results they have found is that if you compare the treatment versus side effect ratio, it is best with 0.05%. In terms of spherical equivalent refractive change and axial elongation, 0.05% is better than the other two concentrations of atropine. However, there are some unanswered questions. One is that we don't know about the rebound phenomenon once we stop atropine 0.05%. Also, we don't know whether 0.05% works better in the second year of treatment compared to 0.01%. And also, we don't know if there is a rebound phenomenon, which will be the best concentration of atropine which we can use. So a meta-analysis by Huang et al. Have suggested that as of now 0.01%, this was in 2019 I think, 0.01% atropine is still the best pharmacological treatment available for treatment of myopia, at least to start with, because of minimal side effects and least chances of rebound phenomenon. So there are certain limitations of ATOM and LAMP study, and the most important limitation is that all these were done in East Asian ethnicities, China, Japan, all those areas. So there have been studies in other ethnicities also before we extrapolate their data or the data of these studies to other ethnicities, and in India also. And all these studies have found that yes, atropine can be used, or whatever the data we got from ATOM and LAMP study can be used in other ethnicities as well. There are, so how the treatment for or recommended treatment for atropine, different groups have given different kind of treatment, but basically this is the crux of all of them. Atropine sulfate 0.01% is what we use commercially. Dosage is once at bedtime, and whom to recommend, usually between 5 to 14 years. It can be used till 16 years, even I am using that. Usually it is given for simple myopia. It is not given for myopia with ROP or index myopia. And also, we don't start immediately in the first visit, as sir had already mentioned or already been discussed. So when you see a patient of myopia, we need to confirm that there is a progression of myopia. Usually, if the increase of myopia is more than 0.5 diopters at end of 1 year, then we need to start the treatment. It can be lower cutoffs for patients who are more prone to have a myopia progression, like family history of myopia. So how long to continue the treatment? Even WHO recommends that at least for 2 years, you first follow up the patient at 2 to 3 months to see the compliance, and then every 6 monthly. Cycloplegic refraction has to be done at every 6 monthly to confirm the progression. Axial length may not be done according to certain recommendations. And when to stop the treatment? The treatment needs to be stopped if there is no progression of myopia at the end of 2 years, or if it is less than 50% of what we started with. And there is no need to taper the drug, we simply need to stop it. If there is, for patients who are non-responsive, as we have already discussed, you can start, low-dose atropine can be given along with optical treatment like DIMS glasses. A word about pyrenzepine, because this presentation is on pharmacological intervention, though we are not using it, but there is, the basic reason why pyrenzepine went into disrepute was because it has poor ocular bioavailability, and there is an anecdotal report of ion-based ophthalmic delivery system of pyrenzepine, which will be something like a sustained release preparation in the eye to control myopia. So to conclude, low-dose atropine 0.01% is a well-established treatment for myopia progression, especially in simple myopia. It is relatively cheap, easily available, and basically you have strong clinical data, not only to suggest its use, but also recommendations on how to use the drug. And it can be used along with other optical treatment in cases of non-responders. There are a lot of references which we can go through. These are only the references which I found relevant for my presentation. Thank you.
Thank you, sir. Thank you for compiling all that we know about atropine. And as was said, we still don't know what is the right dose. Seems to work in East Asia, seems to work in India, not working in America. Still a lot of controversies, and I invite Dr. Rohit sir to throw some light on that. And the controversy even begins with, do we treat a pre-myope also?
And yeah, Satyajit, my job was to raise more controversies, and maybe after the session we'll all go more confused. In binocular status, we talk that confusion gives rise to stereopsis. So when we generate confusion, we will have a better 3D and depth perception about this problem of myopia, which all of us have to come together and tackle. So I'll just run through some of the controversies that are floating. So sit here so that we can have some discussion post. And I'll just run through some of the controversies that exist in myopia management, and maybe post discussion we can take about it. So we've talked about a whole lot of interventions that are there. Some very interesting interventions have come up, particularly in the form of light therapy, and we'll discuss that a bit, but very little is known about that. So we know that the basic debates are that, efficacy and long-term outcomes. So there is question still, while we have seen through some super outcomes of some great studies, as we'll see, there are some very many questions on each and every of the intervention we've talked about. So there are questions and variability in all studies and all countries, in different countries, about the effectiveness of each and every of this modality. So what works for us, what works for Indian pigmented eyes, what works for that one child we are trying to treat, we are not sure. Whether this effect can be sustained over many years or not, we have data for good concrete data for, say, atropine or even glasses in a small number for, say, a year, 2 years. But what's going to happen, because if I catch a child at 7 years of age who's going to progress to, say, 15 years of age, is my intervention going to be sustained or not? Safety concerns, we know that atropine is effective. We know that it possibly works, or we conjecture that it works through muscarinic receptors, maybe in the choroid or in the back of the retina or in the sclera, but I'm sure God didn't make those receptors for us to halt myopia. They have a function. We are halting or we are blocking some receptors in a child in a visual system that is growing. I don't know what's going to happen in the long run. I hope it's not like another thalidomide tragedy waiting to explode. So again, I'm just giving you, I'm like a naysayer, just telling you, be careful in what you do. We don't know the side effects, does not mean that there are no side effects. We don't know long-term consequences, doesn't mean there are no long-term consequences. There are still a lot of consensus guidelines have come up all over the world. Still there is absence of clear standard guidelines. And of course, I mentioned that compliance is a big challenge for everything. Again, unrealistic expectations, the ones that we are building up in our therapy or with the patients, are again another point I just wanted to highlight. So it's important that we can never stop myopia progression. We slow it down, we cannot stop the natural growth. So that's the important thing, must be discussed with the parents. And of course, we have still lacking good long-term data, and our understanding of how each individual patient will behave is still not there. Now, atropine issues that we have, studies have shown a variation of 15 to 46%, which is a huge difference. We found a good 54% efficacy among Indian children, but then how does it act in a larger group, in a larger population? We don't know. The most interesting part was that USA, that till now had not approved and still has not approved atropine, low dose atropine of 0.1%, had two publications in the same very highly indexed rated journal, JAMA Ophthalmology, two publications, one saying 0.01% has no effect and one saying 0.01% is effective. So that's the huge controversy. We don't know. In the biggest and the most financially strong market, there are still disagreements among whether it works or not. The understanding goes that in a low progressive myopic population, which the Caucasians are, a modestly effective treatment, which 0.01% is, you could get equivocal results either way depending upon the population subtypes you have. The potential rebound, we are still not sure what exactly is the potential rebound, and as I mentioned, the long-term safety of anything we are talking about. Optimal concentration, so we know that atropine works in a dose-dependent fashion. 0.01% works in a large group of children, but that may not necessarily be the concentration for that one child you're treating. So we know 0.05% has been shown to be more effective in East Asians. There is a study ongoing in India, so we'll get to know better results. But we know from historical evidence and some of actual treatment that higher doses will be more effective. So if you have a very rapid progressor, maybe you may think of actually making a higher dose for that child and treating him. So tapering versus sudden stop, again, there are no hard evidences to support either way, but we know that rebound exists. Could it be possible that if you taper it, you have a lesser risk of rebound as compared to a sudden stop? How long should the treatment be given? Again, there is very little information on that. I know that the younger I find a myopic child, the longer I know I'm going to give treatment. I have children on atropine for up to 5 years, and I'm kind of struggling what to do with them. So how are we going to taper, or how long is in an individualized treatment? I have to stop or slowly taper and then see how the child responds, and then maybe move on or require a restart on atropine or shift to an optical treatment. So these are things that we learn as we go along. Spectacles, again, a lot of talk about the basis of these concepts of these glasses was this peripheral hyperopic blur. So the concept is that there is a peripheral, the back of the eye is oblate, and therefore in the mid-periphery and onwards, there is a hyperopic refraction that is happening even when we give single vision glasses which we are wearing. But most studies, including the studies that have shown efficacy of these glasses, have not shown that they are more effective or probably effective only in those who have hyperopic refraction. And a lot of studies have shown that that is not true, that all progressive myopes have hyperopic refraction. So the bad news is that the basic concept of these glasses is probably a little questionable, but the good news that the studies have shown us, irrespective of your peripheral refraction, these spectacles may work. So again, it's the way you look at it. There is dichotomy of our understanding, but as we learn more, maybe we'll understand more. And there is a lot of discussion on the various types of spectacles, which one is better, but there is no head-to-head treatment. All have shown good efficacies, and as they work on the same basic principle, possibly all of them would be working to a greater or lesser extent. And of course, they don't have a significant impact on visual acuity in the mid-periphery, but as we discussed some time back, perceptive children can notice the quality of vision difference that is there from seeing in the mid-periphery. There is a variability of response among all individuals, and that is why it is important for us to identify the rate of progression, see for the intervention, and decide what would be optimal in each child. The limitations of spectacles is that we cannot treat a myopia higher than -10 diopters of spherical equivalent. There is a limit to the cylinders they can produce. So therefore, there are maximum limits to our ability to manage spectacles. Ortho-K, unfortunately not very popular in India, very popular in the eastern part of the world. There are questions and queries about the long-term efficacy. The other question is, how accurately is it measuring? The most important thing that matters to me is axial length change. We know that the Ortho-K is flattening the cornea. Therefore, unless I am able to measure the cornea after Ortho-K therapy, after a bit of initial Ortho-K therapy, create a new baseline of the axial length and then monitor and follow up the child for axial length progression, I'm not sure that the pseudo effect I'm getting could be just due to the central flattening through which I'm measuring axial length. So these are key disputes, and maybe that is why there is some rebound that we see in ortho K. And of course, in India, it's unfortunately not very popular, but possibly we are worried about the corneal health changes that can happen with it. And of course, the cost of ortho K therapy. In fact, the cost of any optical therapy that we are talking, there is a maximum power that can be treated with ortho K. And again, the question, is the effect sustained after treatment is discontinued? Because part of the effect is due to the remodeling of the epithelium of the cornea, and maybe it goes back, and therefore there may be an increased rebound, that it was an artificially created improved effect which just comes back as a rebound for us. Multifocal contact lenses, very little studies. In fact, it was the first FDA approved intervention for progressive myopias in children, but again, it's not caught so much, and therefore, again, in India, of course, we don't have its use significantly, but even from other parts of the world, there's not so much about how good it is, how effective it is, or about the standard guidelines. The key most important factor I want to hard hit is myopia, which I now feel is the youngest lifestyle disease. Lifestyle diseases, you say diabetes, hypertension, it's because adults' lifestyles are changing. Myopia is happening increasingly in our younger generation because their lifestyle is changing, accelerated by that huge COVID restrictions that were in place. So it's very, very important. But yet, while we keep hammering outdoor activities, keep hammering environmental modifications, there are some questions we don't know. How much outdoor time is effective? How much time should we send these kids out? Broadly, it's like about 2 hours a day in light. So basically, after dawn, before dusk, the children should be out for 2 hours doing anything what they like. There should be some adequate illumination. What is the amount that we are looking at? Again, these are things that we don't have answers to. Unfortunately, in a hot environment like India, a place like India, risk of sun exposure, the feasibility, I can't ask my son to go out at 2 o'clock in the afternoon when he returns from school. It's impossible. He'll just die of heat stroke. So, before I treat myopia, I'll have, casualties all over. So it's important for us to know that it's, we have to weigh what we have. Finally, red light therapy, we don't know. People have been given very bright light for 3 minutes, red light versus blue light. We don't know what is effective. So this is the last controversy, I hope. So there is still, it's a new treatment, absolutely. We don't know how it's working. We don't know whether it's really effective in the long run. But yes, in fact, a device has already been commercialized and is available in eastern part of the world for therapy, and a lot of studies are going on. So let's see how effective it is. I have tried it, and I couldn't sit for more than a minute or so in that bright light. So kids have to see that for 3 minutes. Again, combination therapy, as I said, we start with one treatment, see how effective it is, and then move on to combination. And we know that possibly optical and pharmacological interventions can augment each other. There are studies demonstrating that. So hopefully we'll learn more as we go on. So I just want to say there is a lot of confusion. Still, there is increasing research, and we are identifying potential benefits, but the key aim should be that management strategies must take into account age of onset, baseline refractive status, the visual environment the child is living in, the compliance, risk benefits of each treatment for that child, and of course the cost. And of course, patients and eye care professionals should involve in informed discussions with each other so that we are able to take optimal care for that individual single child. Thank you.
Thank you, sir, for throwing light on the controversies, but the controversies do remain. So we are open to the audience for, we have an expert panel here, so.
So there is no scientific evidence. We have our past documents talking about yogic exercises. We had seen for a bit. We know that they show remarkable, or they claim to show remarkable effect, and possibly it is because of anterior segment relaxation that happens. So you have that latent hyperopia of about 0.5 to 0.75. Children may have up to 1 or 1.5 also. So when they learn that relaxation techniques, they are able to reduce that latent hyperopia that they have, and that shows remarkable impact, something that we've seen in a few studies on evaluating the anterior segment. But as of now, there is nothing that shows that long-term eye exercises or any yogic interventions can prevent long term. But yeah, yoga done in bright sunlight or during the day, I'm sure will have multifarious benefits for the myopia progression as well as for general health.
I have a suggestion for everyone over here. Why not we shift to 4K light in our houses so that we get sunlight in the room we are sitting? Any opinion? Can we go a research? Can we have a research on this? Because that will be natural sunlight in the rooms, and the kids are most of the times in the rooms rather than playing outside.
So it's not just the spectrum of light outdoors, it's also to do the magnitude of illumination that is the difference between outdoors and indoors. So, you know, the maximum illumination you can, you know, get, it's not even 1,000th of what, you know, you get even in not so bright times. So we don't know whether it's to do with the spectrum only or it's to do also with the magnitude, plus the fact that whenever you are indoors, however big your room, you still have some accommodation there because you're not looking at infinity. So again, we don't know how myopia is progressing. We don't know how outdoor activity is really impacting. Is it just the dopamine levels because of sunlight, or it is because of the you know, horizon? So there are a lot of questions. Yes, a lot of studies, a lot of research has gone on in China and all, where they have actually, I think was being discussed, classroom change. They've changed classrooms with you know, big windows, so the children are studying in brighter light, in outdoor light essentially. So like we can encourage our children, if they are reading, they can read outdoors, maybe on the terrace or whatever. So these are again lifestyle modifications that we could talk in terms of. Yes. Yes. So, so try bringing a law like that in India. But yes, they've come out with this that less than 2 years, no no phones, nothing. 2 to 5 years, 18 minutes. Less than 16 years, 1 hour. 18 to 16, 2 hours. It's all easy. This is what we keep telling our parents. In fact, I tell that, you know, children shouldn't have a smartphone. They shouldn't be seeing through a smartphone. They should get their old Nokias back and see through that. But size of the screen, the distance from where you are, all these are, you know, all these matter.
No, I think, you know, in the similar context, forget about, you know, bringing that big change. But what I would want to, you know, bring it here that even after COVID has been gone, all these schools, you know, they are giving them the online classes and then the homework on WhatsApp. So that is very detrimental. So I think that is a very baseline. Probably we can, as an ophthalmic society, we can make it a compulsion because for them it's easy, you know, one click, it's going to the 1,000 kids. So I think we need to that change first to reduce, you know, the screen time for the children. One more thing, I think what Dr. Rishikesh Mai has, you know, given probably, you know, the recommendation that must and, you know, the optional. So I think the axial length, it should be also in must, right? Because without knowing the axial length every time when patient comes, you know, it's very difficult to take a call and decide, you know, how's the child doing as far as progression is concerned. And that's very easy, right? All we as an ophthalmologist, axial length can be taken very easily in an outdoor clinic.
In a Karyapati IDC study in 2005 done by Aravind, I think more than 2 lakh children were involved. They have divided different groups. So children from rural India and children from urban schools. Rural India means completely rural India where they go only 3 to 4 hours for school, and the urban India where they go for more than 8 hours school. And the percentage of refractive error incidence in urban India, urban schools was more than 7 to 8% in 2005. And the rural India, the percentage was 1 to 2%. When they repeated this study again after 5 to 6 years, the percentage increased to 11 to 17% in urban schools. In rural India or rural schools, it maintained almost 1 to 2%. So that itself shows that apart from the incidence, the prevalence also is being increasing and the progression is also increasing. So there's definite environmental effect is there on the children. This is one aspect. The other aspect is we are looking at sunlight exposure. what aspect we are not looking at is how much the child is looking at distance, infinity, how much he is exposed. See, in the home, we are not looking beyond 10 feet. At the school, we are not looking beyond 15 feet. You go out, everything is a 3-story building, even in the district headquarters. So we are not looking beyond 30 feet. So where is the chance the child is getting beyond seeing 30 feet? So obviously brain is getting a feedback that he has to see only till 30 feet, not beyond that. So maybe we don't know what is the, what brain is thinking and how it is modulating and what its effect on the elongation of the eye. We really don't know. So it is not just the sunlight alone. I think it is open ground playing that has to be established for more than 2 hours. And also seeing the horizon, as Rohit rightly said, exposure, seeing the distance, that also makes a lot of difference.
As far as outdoor exposure is concerned, according to studies, the outdoor activities can prevent the onset of myopia. But once it sets in, the progression of myopia cannot be controlled with outdoor activities only. That's what I said.
Yeah, so it's been a nice discussion. I've got a comment to make regarding orthokeratology. So I have been practicing for past 10 years and I've got over 100 children over 2 years follow-up and 20 children who have completed more than 5 years follow-up. Now I feel there's an apprehension amongst all about microbial keratitis. Now I would like to say that I have not had a single case of microbial keratitis. So I feel till now wherever optometrists are practicing that. So if ophthalmologists take more interest, I don't think there'll be many cases of microbial keratitis. And secondly, if this lens is prescribed after training to children, you see, most of the time we just prescribe it. We don't go into the details whether the child can put it on, take it off, and whether he takes the precautions. So that concern, I think people are more scared. So if once more people adopt this technique, then I think we should think about that. And as far as the effectiveness is concerned, I would say it's very effective. Thank you.
I have just one point for the panel. Actually, how many of us are prescribing atropine with the documented progression of about 0.5 diopter? Usually what I would think would be, if I have a documented progression of 1 diopter in 1 year, I would consider atropine. Does everyone go ahead with 0.5 diopter increase?
It has been recommended in the consensus guidelines, and we are following that actually.
That's what you mentioned, that's why I'm asking.
Yeah, I'm using 0.5.
I would say I would still, for more than 0.5, I would consider it as a significant increase. I mean, that's how we've defined and classified myopia progression as more than 0.5 diopters change over a 1-year period. So it does not necessarily that you need to have a pharmacological or an optical intervention. You could just intervene by lifestyle changes. But yes, it becomes a cause for concern. It becomes a reason to intervene in whatever way you want it to.
Thank you.
I just have one more question. Can I, sir?
Yes, please.
I have one question. So I have seen some pediatric ophthalmologists, they advise twice a day BD dose of atropine, 0.01. But most pediatric ophthalmologists, they are preferring once a day at the night time. So what is the panelist, all of your preferred practice pattern?
So the scientific evidence says once a day. There is no study as of now that has shown that twice a day or 2 drops 5-minute interval, which has been discussed in different forums, would be better. It's just like, as understanding it would be that BD dose may be a little more effective, but as I said, there is no evidence at the moment that can shed light. I think there is a study internationally somewhere that has been just registered on OD versus BD, so maybe results will come, but there is also evidence, but currently concrete evidence is if there is not adequate effect on 0.01, 0.05 is better, so maybe you have to take a call on that. So, but as of now, one can't say that it is definitely better. People have tried it, some say that it is better, but again, like I said, concrete evidence is yet to come. So, if there is nothing else, I think we will thank AIOS, thank and Todd for giving the opportunity to discuss this extremely important topic. And we hand over the space to the chairman scientific.
So one last query, sir. Actually, I've been using atropine for more than 10 years now. It was before it was commercially available, so I used to dilute for my patients with tear substitutes. So the biggest change I had when it became commercially available was the kids were refusing to put, obviously, because it's much more burning. It's no longer a lubricant. So suggestion from your to the industry side to add a lubricant so that it becomes more kid friendly.
Okay, sure. Thank you. Absolutely.
Thanks. Very good session. Beautiful. Excellent.